Good afternoon. Let's begin. I'm Michael Erickson. I'm Dean of the Institute of Public Health, and we have a very special day today. A number of things are going on at the university, all related to public health and global health, and we're trying to tie it together as much as possible to have a meaningful experience for the university and all of those who care about public health and global health. We'll hear from our guest speaker today, and I'll introduce him in a second, who will talk about global health challenges in the 21st century. And then we also are very fortunate today to have a number of international guests with us who will be reacting to Dr. Koh's remarks from the perspective of the BRICS countries, Brazil, Russia, India, China, and South Africa. And we're fortunate to have three visitors here from China, Brazil, and India who will comment on Dr. Koh's presentation. The goal is to really increase our understanding and appreciation of the U.S.'s role in global health and how that can help advance both global health around the world, but also in turn lessons we can learn that will improve health back in the United States. So we're looking forward to a very rewarding and stimulating time, chance for questions at the end as well. So let's begin. I'd like to introduce our real keynote speaker, Dr. Howard Koh. Howard is a longtime friend of mine. He is the 14th Assistant Secretary for Health in the United States in history. He is a very talented man who is easy to embarrass, so I'll try not to do his full bio, but I'll just point out some of the most noteworthy things about Howard. He's a graduate of Yale, and he was president of the Yale Glee Club. So not only is he a scholar, but he's also a talented artist. He is board certified after his medical school at Yale. He is certified in internal medicine and hematology and medical oncology and dermatology. So he has 4 board certifications, a very talented physician. As he was saying earlier at lunch, he felt his mission in life was to cure people and to treat people. And then he discovered public health. And that public health not only cures people and treats people, but also prevents diseases from occurring. And has devoted his career to advancing the public health, currently as Assistant Secretary in the Department of Health and Human Services. And prior to that, he was the Commissioner of Health in the state of Massachusetts during the time of 9/11 and during the time of implementing healthcare reform in the state. And prior to joining the department, he was a professor, the Harvey Feinberg Professor of Public Health Practice at Harvard University. So Howard is an extremely talented young man, I can still say, and has accomplished a lot. But those of you who know Howard know his accomplishments, but most notable of Howard is not what he's accomplished professionally, but he as a person. He's a warm and very caring and compassionate public servant who has given up a lot to serve us all in Washington, which, as you know, is not an easy place to be. It's often not appreciated and very difficult, and we really do appreciate you, Howard, doing what you're doing and being here today, so thank you.
Thank you so much, Dean Erickson, for that very, very warm introduction. You did embarrass me. And not everything you said was true either, especially the young part. So, but I'm absolutely delighted to be here at Georgia State University and feel the brilliance and commitment and passion of the people in this room, starting with your extraordinary dean. I've known Mike for a long time, as he mentioned, and he has been very much an inspirational figure in public health history, particularly in tobacco control. So it's a real source of inspiration to have Mike host me today, and we just had a wonderful luncheon and got to meet some extraordinary colleagues, some of whom are hopefully going to say nice things about me in just a couple minutes. But this is a trip that I've been looking forward to, and I'm really humbled by the talent that's been assembled here in Atlanta. It reminds me of the saying that the last time there was more intelligence in one room was when Thomas Jefferson dined alone. So, and this is a visit that's been in the works mostly because a dear colleague of Mike's and mine, Rosie Henson, who's my senior advisor, set this up. Rosie, can you just stand up and get a round of applause here? One of the joys of working in public health is you meet these fascinating, wonderful, inspiring people. Rosie is at the top of the list. Everybody knows Rosie Henson. If you don't know Rosie, go up and introduce yourself after this meeting, and you will join her extraordinary public health community. But I feel very much a part of Georgia State already, hearing about your history over the last 100 years, hearing about your commitment to public health, and hearing about your commitment to global health at this extraordinary time. I did want to mention I'm joined by several other colleagues from the Department of Health and Human Services, HHS. Kirby Bumpus is my special assistant, a public health school graduate, not from Georgia State. I won't tell you what the institution is, but I'm delighted that Kirby is here. Admiral Clara Cobb is our regional health administrator here in Region 4 in Atlanta. And I'm also delighted to have my colleague, Dr. Marcus Plesher from the CDC, who heads cancer prevention and control here. So we're very pleased to join with all of you. Did Dr. Satcher stay? He had to leave, and it was just a joy to see him. And there's so many distinguished colleagues who were just at this luncheon that we just enjoyed. And the timing of this meeting is also extraordinary because this coming weekend begins the World Health Assembly in Geneva, the 66th World Health Assembly, I am told. So I have the great pleasure of joining Secretary Sebelius and the U.S. delegation to attend yet another historic global health meeting there. So this is a time that we're all thinking about public health and global health, what it entails in the 21st century. So I do have some thoughts to share, and then I'm very eager to hear what my colleagues are going to say in just a second. And when you're asked to address a topic like global health in the 21st century, you can obviously think about a lot of issues to mention and many ways to tackle that topic. On one hand, you can say, oh, well, we have a huge planet here with some 7 billion people of vast backgrounds, diverse cultures. Each person is running into his or her own unique health challenges. So that's one way of looking at the topic of global health in the 21st century. But another way, and I think a way that you all embrace, is that we are one planet and the world is getting smaller. And that in an environment like this, where public health is more complicated by the day, both domestically and around the world, we need to learn from one another by the minute. And then we share so many things in common, regardless of what our background is. To paraphrase John F. Kennedy, we do all inherit the same earth, and we all breathe the same air, and we all dream for a better future for our children, and we are all mortal. One of the most beautiful sayings of the late president. And the themes of global issues is one that's very personal to me because I'm Korean American. My parents journeyed to the United States a generation ago searching for the American dream. And when you have the privilege of serving your nation, as I have had in the last 4 years, you think every day about this journey and how you got here. And that, of course, starts with your parents' journey and the sacrifices they made. So because of my background that comes from Asia, I've lived a life where I've thought about culture and global forces and how it impacts people's lives, and in this case, people's health, just about every day. Now, I started my job in 2009, as Dean Erickson mentioned, and literally on the first day of my job, a number of public health themes came to the fore, particularly on global health. We were all thrown into H1N1 planning, and that was an incredible time where we were working closely with partners from Mexico, Canada, organizations such as the Pan American Health Organization, PAHO, and also, of course, World Health Organization, WHO. And then through that year, in this country, we saw 2 simultaneous flu vaccination efforts conducted through that season. One, H1N1 vaccination, which is all publicly funded and publicly coordinated. And the second one was, of course, our traditional seasonal flu immunization, which is largely privately based and needs many partners to put that together. So that was an extraordinary beginning to the Obama administration and health, and for me personally as the Assistant Secretary. Not long after that, we experienced the earthquake in Haiti, and we had close collaboration with many partners there to work with the Haitian government in terms of rebuilding that public health system and the infrastructure there. Among other things, I oversee the Commission Corps of the United States. Admiral Cobb is one of our wonderful leaders, and the Surgeon General's office. So we deployed some of our officers to Haiti and was involved in that international collaboration. One of our wonderful leaders in the Assistant Secretary's office, Dr. Nadine Gracia, is Haitian American and was very, very involved in some of the ongoing recovery efforts. So those are some things that come to mind right away when we think about global health in the first term of the Obama administration. And then, as you well know, we have had a history of the U.S. working around the world with partners in key infectious disease issues like HIV/AIDS, with some 34 million people now infected worldwide. Last year, I had the absolute privilege of speaking before the first international AIDS meeting held in the U.S. in the past 20 years and celebrating some of the progress in that vital area. We have key issues like TB and malaria that kill some 1.2 million people each. We've had progress in improving maternal and reproductive health. And also, we've had some remarkable achievements in this country and around the world in increasing life expectancy and reducing infant and child mortality. But despite this progress, being in public health means that our work is always unfinished business. That's just the nature of what we do. And as you heard from Mike, I started my career as a clinician, trained in multiple fields, particularly in cancer, wanted to go out and cure every patient put before me. And I quickly saw that while being a direct care provider is a very noble and sacred experience, and I had the privilege of taking care of patients for over 30 years before coming to Washington, that there are many other ways in addition to promote public health. And in these times and in jobs like these, you always start with the basic definition of health, which keeps expanding. I love the World Health Organization of Health, which is, quote, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. I love the fact that they refer to physical, mental, and social well-being. And if you've had discussions about what is health and how do you define it, what are our goals, the concept of spiritual health now is coming up more frequently, which I think is so critical to giving meaning to our work. In short, the World Health Organization has also said, and this phrase is hanging on the wall of Dean Erickson's office, I notice, our work is to help each person reach what's called the highest attainable standard of health. I love that phrase, the highest attainable standard of health, no matter how you define it. So if that is indeed our goal, we understand that our good health is a gift, and we have to protect it, and we have to be creative and committed and involved for the long run, always understanding there's unfinished business, taking the broadest view possible, and building as many partnerships, often untraditional partnerships, as possible. Now, on the global front, probably everyone here knows that in 2000, some 8 Millennium Development Goals were put forward for the world to aspire to and to try to reach by 2015. And some of those goals involved eradicating poverty, achieving universal primary education, achieving gender equality, decreasing childhood mortality, increasing maternal health, tackling key infectious diseases, moving toward environmental sustainability, and building better global partnerships. What is very striking to me about that list is the global public health community had already embraced, by putting forward those 8 goals, the social determinants of health concepts. That means that we can improve people's health by focusing on biology of disease, of course, but we also have to understand that there are many other social forces interacting and affecting people's health in addition to biology of disease. And as I like to say lately, health is much more than what happens in a doctor's office. Health starts where people live, labor, learn, play, and pray. And since I made that up, I'll say that again. Health starts where people live, labor, learn, play, and pray. So if you have the vision of the World Health Organization and you say of our 8 MDGs, Millennium Development Goals, we're going to talk about eradicating poverty, helping people to promote the best educational attainment possible, gender equality. That's a social determinants approach to health, which is where we need to continue to go in the 21st century. So that's something that we in the United States are learning more about from our global partners, and the social determinants approach is going to be the future of global public health, I can assure you. And I'm eager to hear my colleagues about their thoughts on that concept as we move forward. So where are we with the state of health in the world right now in May 2013? I hope all of you saw the absolutely historic release of the Global Burden of Disease in January of this year in Lancet. For those of you who are not familiar, this is a project that's updated regularly by some 500 investigators over 50 countries, led by my former colleague at Harvard, Chris Murray, where they look at the health of all 7 billion of us in some 187 countries, the state of our health in 2010, look at the cause of death for the 53 million people who died in 2010, and make some conclusions about the state of global health in the 21st century. In this astonishing report, we could summarize it in some fairly simple, perhaps too simple ways, but for the sake of being succinct, let me give you some of the highlights that jumped out at me when I reviewed this yet again. This report showed that the health for much of the planet's population is rapidly looking like some of the health issues that we see here in the United States. Of course, we have to keep our focus on infectious disease, TB, malaria, HIV. And by the way, we have a very aggressive domestic HIV program here with a national HIV strategy unveiled personally by the President in July 2010. It was an honor for me to be at the White House when that was unveiled. And of course, the PEPFAR program, the President's Emergency Plan for AIDS Relief, that was pioneered by President Bush, is a historic legacy that we should all celebrate. But having said that, in this Global Burden of Disease report, we note some trends. First of all, deaths in children under 5 have dropped some 60% since 1970. And that's because of really focused work by the global public health community on vaccines, on antibiotics, on better maternal and child care, in short, trying to reach the Millennium Development Goals. A second theme that came through on this report is that we do have obviously ongoing issues with malnutrition and starvation and too little food. But like we have here in the United States, more countries around the world are starting to see a challenge with too much food. In fact, in terms of causes of death, malnutrition dropped from 11th to 21st in this report. As one author has recently said, that part of the challenge now globally is that people are not starved, but stuffed. And that's an issue we're talking a lot about here in the United States, as you well know. A third big message that came forward in this Global Burden of Disease report is that life expectancy is increasing for men and women around the world, and that's great news, of course. Men now live on average to 67.5 years, up from 56 in 1970. Women live to age 73 on average, up from 61 in 1970. So that's great to have increased quantity of life, but the countervailing part of that situation is that too often people are living longer lives with more disability. And this report focused on disability heavily for perhaps the first time, looking at issues like mental health and emotional well-being, diabetes, substance abuse, and other themes. And then the fourth major theme that came through, particularly relevant for today, is that 2/3 of deaths around the world are now due to non-communicable disease, what we call NCDs. Everything in public health has an acronym, by the way. Have you noticed? So heart disease and stroke are still the biggest killers around the world, but NCDs, non-communicable disease, have grown in significance. This is not to diminish the importance of infectious disease like HIV, TB, malaria, hepatitis, where we need ongoing commitment. Cancer deaths were now some 8 million in 2010. That's much more than in 1990. Lung cancer deaths have risen. That should be almost completely preventable, and that's due, of course, to tobacco addiction. I'll be saying more about that in just a second. Of course, Dean Erickson is an international leader in that area, as is Rosie Henson and other colleagues here. So those are some of the new themes for global health in the 21st century that the United States and the rest of the world has to grapple with, and what we're going to be facing as we head into this World Health Assembly in Geneva this weekend. So for the rest of my presentation, let me comment briefly on a number of key themes. First, what's the strategy to face these challenges, particularly the challenge of NCDs, non-communicable disease, from both the US and global point of view? Is it time to make more of a paradigm shift to think more about non-communicable disease as well as infectious disease as part of the global health conversation? Secondly, how do we set goals and how do we measure progress? Third, how do we make the social determinants live on? Because health starts where people live, labor, learn, play, and pray. Did I mention that already? Fourth, the absolute essential contribution of universal health insurance coverage. And of course, the US is going through a historic evolution on that topic as we speak. And of course, I'll be saying more about that. And then I'll close with just a couple of minutes on perhaps best practices on moving the NCD, non-communicable disease discussion forward. So first, with respect to strategies, our Department of Health and Human Services is an extraordinary place. For those of you who don't know federal government, this is a department with some 80,000 employees, a budget over $800 billion. And while the chief mission of the department is domestic, we have an outstanding Office of Global Affairs headed by my wonderful colleague, Assistant Secretary Niels Dallaire. We have 11 major agencies, including the Centers for Disease Control and Prevention, CDC, the National Institute of Health, NIH, the Food and Drug Administration, FDA. Everything has an acronym. By the way, my office is OASH, the Office of the Assistant Secretary for Health. And I'm known as the ASH in my building. And if I can say, as one who has spent a good part of his life in tobacco control, to be called the ASH is a little bit ironic. So the mission of OASH, my office, is mobilizing leadership in science and prevention for a healthier nation, and in this case, a healthier planet. And that's why it's a pleasure to have my colleagues here working with me every day to make sure that we have as many partnerships as possible to promote the message and the theme of health. Now, we also at HHS, Health and Human Services, have the pleasure of working with other government agencies, the U.S. Agency for International Development, USAID, the State Department, and my brother Harold actually just left that department as a legal advisor under Secretary Clinton, so that was a personal privilege for me. And of course, my mother was very happy to have 2 Senate-confirmed sons in the Obama administration. And the department also developed a global health strategy for the first time, which Secretary Sebelius unveiled, where some explicit themes of the importance of implementing and evaluating research, policies, and programs with international perspectives, emphasizing transnational health issues, determinants and solutions, and promoting interdisciplinary collaboration were key themes for our department going forward in this very critical time. Now, with this backdrop through the U.S., even in the first administration, we have seen the global community start thinking more about the non-communicable diseases and NCDs. And it was just a privilege to attend the UN General Assembly high-level meeting on non-communicable diseases in 2011 in New York City, a delegation led by the Secretary. I was very honored to go. And that was historic for the UN because that meeting was only the second time in history that the UN General Assembly has held a high-level summit on a health topic. The first one was on HIV/AIDS in 2000. The second one was this meeting on NCDs in 2011. And to spend a number of days with heads of state from around the world actively engaged talking about issues like cancer, cardiovascular disease, diabetes, chronic lung disease, tobacco use, alcohol, unhealthy diets, physical inactivity, as well as the traditional topics of TB, malaria, HIV, was pretty extraordinary. And it's a very, very exciting time. And so this upcoming meeting that starts this weekend, we are going to be hearing more about a strategy for tackling the NCDs as a global community. And in fact, last May, the World Health Assembly adopted the first global target for after 2015, that is to reduce premature deaths from non-communicable diseases, NCDs, including cancer, by 25% by 2025. There are ongoing discussions about other target setting with respect to sugar and salt consumption, about improving global dietary intake, and talking about other social determinants' impacts on our health. So we are very, very much looking forward to these conversations next week. In 2011, when I was at this UN meeting, I knew there was a shift when I went to a luncheon meeting and one head of state got up after dessert and talked about how many times he had been colonoscoped and how that made him a better leader for his country because he was truly committed to prevention and non-communicable disease control. So I thought that was pretty historic. You know, you usually don't hear that at global meetings. We can offer some help, we believe, in terms of measurement and tracking progress as these MDGs conclude after 2015 and a new set of targets get proposed. Because here in the United States, we have a process of target setting called Healthy People that's gone on since 1979. And for those of you who do not know, in the United States, every 10 years, our country puts forward goals and targets for the country. And then we track these in a very transparent and public fashion and report back to the American public whether we have made progress and made our country healthier. Several years ago, as the Assistant Secretary, I had the great privilege of unveiling Healthy People 2020. I like to say we need 2020 vision for a healthy people. And unveiling that and talking about the some 42 topic areas and over 1,000 objectives is a fascinating discussion. And I don't know which one of you are teachers or students in any classes, but if you want a topic for discussion in any public health setting, just pick out a Healthy People goal, put it before a group of people and say, how do we best reach this goal as partners, as a society, by maximizing all the contributions and talents from as many people as possible, and I will assure you, you will have a fascinating conversation. So healthypeople.gov is our website if you want to access these goals and targets. We also have what's called leading health indicators, 12 topic areas, where monthly we review a new high priority goal and talk as a nation about how we reach them. Our department now sponsors monthly webinars on healthy people goals and leading health indicator goals, and our webinars now routinely attract a couple thousand people at a time. So it's a great way of bringing people together to talk about strategy and about aligning our efforts for progress moving forward. I should mention also that as we talk about these broad healthy people goals, under the leadership of Secretary Sebelius at our department, we have unveiled over a dozen strategic plans in areas like health disparities, the first ever tobacco action plan, new action plans on HIV, which I already mentioned, on hepatitis, on health literacy, and also a national prevention strategy for the first time that's based on Healthy People Foundations. So this is all a level of commitment that I don't think we've seen ever before, and we're very proud of it. And we're also very committed to holding ourselves accountable and tracking over time the progress we've made in these deliverables with these strategic plans. Now, with respect to the theme of universal coverage, we in the United States are in a fascinating and critical time right now with respect to the Affordable Care Act, which you know was signed into law by the President March 23, 2010. We are now past the third anniversary. And January 2014 is a key date because for the first time the American people will see full implementation of health reform and see the promise of this historic law in its entirety. I'm from Massachusetts, so that state passed health reform in 2006, as Dean Erickson mentioned, and I got to witness how that state of some 6 million rallied around a new law, which was bipartisan, Republican and Democrat, and how 7 years later, Massachusetts has the lowest rates of the uninsured of any state in the country, some 2 to 2.5%. There is broad support in that state that this was a worthy investment and a historic commitment. So we are hoping that as the American people sees more of the Affordable Care Act, particularly after January 1, 2014, we will see the impact not only for better insurance for many of the 50 million uninsured right now in the United States, but also better care, and then very importantly to this audience, better prevention and public health. We already have many examples of progress of what health reform has accomplished in this country. For example, many of you are young students here, and you may or may not know that we now have some 7 million young adults under age 26 on their parents' insurance plans. Some 3.1 million achieved insurance status that way after the Affordable Care Act was passed. So we're very proud of that. We are very proud of better drug coverage for Medicare seniors and people with disabilities and closing the so-called donut hole gap. We also are very proud that the law outlaws discrimination against those with pre-existing conditions so that nobody will be turned away, no one who wants insurance coverage. One provision that really struck home for me as a clinician is that after January 1, there will be no more annual limits or lifetime limits on coverage for patients. And I don't know about the providers here in this audience, but I have too many memories of patients, very sick patients, trying to get better, who are spending most of their time wondering if their insurance would run out and they would have the support and security that they needed and deserved. Well, after January 1, those days are over, and so that sick patients can concentrate on getting better, and clinicians and providers can concentrate on helping them get better without worrying about whether insurance coverage will be abandoned. You all know that right now every state is going through a discussion on whether to establish a state-based so-called exchange where new insurance options will be made available for eligible people who apply. And also discussions about Medicaid expansion are occurring in every state in this country. So it's an absolutely fascinating and historic time. If you want to know just some basics about health care options going forward, please visit healthcare.gov. It's our website that we try to update regularly. put it in simple language. You can sign up for email bulletins and updated information. After October 1st, you can sign up for coverage in one of these marketplaces, and after January 1st, that coverage will kick in for those of you who are eligible. So in the last couple of minutes, let me just cite some best practices, particularly around NCDs, that might engage all of you and my colleagues on the panel. I trained in cancer, as Dr. Plessia knows, and so a privilege for me now is to see the potential of public health and cancer control and cancer prevention. Cancer treatment is potentially life-saving and critically important, but can we also have a commitment to public health and cancer control and cancer prevention? That's how I started my career in public health, particularly in the area of tobacco and also melanoma and skin cancer. We have, through the National Cancer Institute and Dr. Varmus, lots of cancer collaborations globally. They're increasingly talking about cancer prevention and control as well as treatment. About 6 months ago, I joined Dr. Varmus as he invited 40 cancer center directors from around the world to talk about how we can make the biggest impact on preventing cancer and controlling cancer deaths in the future. And that was an absolutely fascinating conversation. And it was great to see these cancer directors becoming basically public health leaders. The tobacco issue has got to be mentioned in every global health conversation. And again, great thanks to Mike Erickson and to Rosie Henson and to Pam Redmond, who is doing some incredibly important work here. You hopefully know that this is the leading cause of preventable death worldwide. There is no other condition that's going to cause 1 billion deaths. That's 1 billion in the 21st century. And we have an industry that has pumped millions and billions of dollars into promoting products to their target audiences and trying to normalize tobacco use in our society with devastating consequences. So in this fascinating topic, a global strategy is to denormalize tobacco use and reclaim the social norm for health and wellness and tobacco-free and smoke-free environments. That's what we're trying to do in this country, and I know many of you are doing that around the world. We have some great progress in this country with respect to regulation. June 22nd, 2009 was when the President signed our historic Family Smoking Prevention and Tobacco Control Act, giving our U.S. Food and Drug Administration historic authority to regulate tobacco. I'll never forget June 22nd, 2009, because that was my first day of work. And I showed up at the department. I was told to go to the Rose Garden and support the President as he signed this bill into law. So that was a day where I said to myself, this cannot be an accident, that this is somehow destiny and a journey that I was meant to do. So as the FDA is doing their important work, we, in addition, are continuing to try to change the social norm. Hope many of you are seeing the Tips 2 advertising campaign sponsored by the CD right now, because the more we talk about the importance of tobacco control and tobacco prevention, we denormalize this addiction and restore some hope for a healthy future for our kids. In this country, we are having efforts, for example, to establish smoke-free and tobacco-free colleges and university, and that is literally catching fire in a way that we're very, very excited about. And then globally, at the UN General Meeting in 2011, we unveiled a so-called Global Smoke-Free Worksite Challenge. And we have been proud to have partners around the world, especially and including places like China. You can imagine how difficult it might be to reclaim the social norm of health in a place like China. But in the luncheon where Dean Erickson asked me to come, we were actually at a China-US smoke-free worksite event where a number of business CEOs said, we want our workers to be healthy, we want our worksites to be healthy, it's got to be smoke-free. If you're following this internationally, Russia, in fact, is now about to unveil a historic indoor clean air law, And people said that couldn't be done, but it's being done as we speak. So we're changing the social norm. And I do want to point out that the first country that went smoke-free nationwide was Ireland in 2004. It was fascinating to watch that development. And they said, we want to make all public places smoke-free, including restaurants and pubs, and pubs, and pubs. And they said, oh, you can't do it in pubs. That's normal in Ireland. But somehow, when did that become the norm? So Ireland has reclaimed the social norm of smoke-free public places, restaurants, and pubs. And it's starting to make a difference. And we now have several dozen countries around the world that's doing that in a very dramatic fashion. My last comment here is now on obesity, and it's been a privilege to be part of the Obama administration where the First Lady has taken on such a high-profile leadership role in promoting Let's Move to solve the challenge of childhood obesity in a generation. For those of you who are tracking this, this is a social determinants approach because it's promoting physical activity, of course, which is great. It's promoting healthier child care centers so that there's better nutrition in child care, less screen time for kids at a very vulnerable age. In schools, in the 101,000 public schools, the U.S. Department of Agriculture has introduced healthy breakfasts and school lunches, and that's changing that nutritional environment. We have Let's Move cities, towns, counties, where mayors have announced that they want to be leaders in their communities, and this is where we again recognize leadership. And we are very committed and proud that the private sector is stepping up because the food and beverage industry also recognizes that it is good business to promote healthier foods. And just recently we heard, for example, that Disney is cutting all advertisements for unhealthy foods from their kids' programming. And then just a couple months ago, Reebok and Nike donated some $80 million to invest in organizations to promote physical activity and fitness in the school setting. So as I close, I want to thank you for your interest in global health in the 21st century. It's a fascinating, absolutely historic time. And we are seeing the world getting smaller and uniting around some very common cosmic themes. You know that every person in this room can make a contribution to make the planet healthier. And in the end, it's all about helping each person reach their highest attainable standard of health. It was Maya Angelou who said, to survive is important, but to thrive is elegant. And that's what it's all about. Thank you very, very much.
Thank you, Dr. Ko. We'll have a chance for questions in a couple of minutes, but right now we're going to ask some of our international guests to respond to what they heard Dr. Ko say, give a little bit of perspective from their country. And again, we're very fortunate to have going on simultaneous to this talk a 3-day workshop with international experts exploring the area of urban health and measuring health in cities around the world. Our colleagues, 2 of them I've been able to visit in their cities and establish a relationship between Georgia State and our international university colleagues. I'll ask Dr. Fu Hua to start. He is the Deputy Dean of the School of Public Health in Fudan University in Shanghai. It's one of the premier, probably the premier public health school in China and one of the leading universities in the country. So please, a couple minutes of comments.
Okay, thank you. Thank you, Mike. I think, yes, it's very, very great to listen to the presentation of the Dr. Ko. I think in China, when we talk about the disease burden, also, for example, Dr. Ko mentioned about the global burden of the disease. In China, the double burden also, for example, the infectious disease, also non-communicable disease, also very, very heavy. And I think, for example, talk about infectious disease. but we face the challenge from the blue flu H7 and 9, but for this and for example for the diabetes, we also have about 10% of the prevalence of the disease, and also obesity about 20%. So I think that compared to the United States, maybe you don't have the environmental problem. Also, we don't have the food safety problem, but we also will have such as very big the environment problem, also the food safety. In addition to, for example, for the lifestyle change, also, and for example, the tobacco, also physical inactivity, also the diet. I think so. In China, we face both, but for me, I think that one big challenge is come from the commercial forces. It means that for the globalization, economic development very fast, and also the commercial force is much important for the public health. For example, for tobacco, and for the food, for the environment, and this commercial force is much the promoter, the lifestyle change, or also another thing. So I think for the public health, how can we use another force? For example, community force. Also, for example, how to empower people to against the commercial force. I think is much important. Tobacco control is a good example. We hope use, for example, the tobacco control, this example for the solve another NCD problem, but it's not easy because it's much the culture related, and we hope to learn some from the United States, but we also have our problem. Just Dr. Coates mentioned, is the social norm is much complicated. So I think that we should work together for resolve this the globalization, the public health problem from the globalization. So we hope work together for this. Thank you very much.
Thank you, sir. So Howard, when you come back, you can talk about some of these points around commercialization, globalization. Next, we'd like to hear from Dr. Eduardo Mota. Dr. Mota is Dean of the Institute of Collective Health in the University Federal de Bahia in Salvador, Brazil. And I had many of us from the university had the great privilege of visiting Dr. Mota earlier this year at their university. And we're pleased to have one of our faculty, Christine Stauber, who will be doing her Fulbright Scholar Award at his university next year. So Dr. Mota.
Good afternoon, you all. Thank you, Dr. Erickson, for this opportunity. In fact, a wonderful opportunity to see Dr. Coe's ideas on global health. In fact, more than ideas, his positive thoughts on global health really inspires us. This is the second time I listen to Dr. Coe's, and as before, it's really a listening experience. Thanks, Dr. Coe, for your comments and your ideas. I'll begin just talking and making some comments on the role of the U.S. on global health. And I'll do so on the perspective of my country, of Brazil. And to do that, I will remind of the Millennium Goals, how was important the way U.S. and some other countries enforce the Millennium Goals, in the sense of talk to other countries how important the Millennium Goals were. And I could follow the impact of that in my country, how it mobilized government and how it mobilized the society. So, and now with universal coverage, I'm expecting the same thing. As you know, Brazil has a public universal health system, which is also of universal coverage, and we already feel the impact of the decision in the U.S. to go for universal coverage, how it is supporting the development of our health system. With these comments, I want to just point there, when countries like the United States begin talking about nutrition or exercise, the impact on health policies in other countries, mostly developing countries, is absolutely fantastic. So the responsibility of leading countries like U.S. to be leaders on health issues, mostly on prevention, promotion issues. And in that sense, I guess what you said, not only about global health, but about what's happening in the U.S., is following very carefully to everyone, both scholars and government in Brazil. I have two other comments that I want to hear from your experience. One is, how can we translate scientific knowledge and evidence into decision and action? I'm now back to the academic life, but I spent some time at a county level health government. And the difficulty was to make this translation. So now that you are in government, in a government position, how can we make it easier and faster, this translation of scientific knowledge into action? In your experience, how it happens in your office? And the other point is, WHO is at least part of the World Health Organization talks about health in all policies. I think this is a very powerful concept, mostly for local government. There are some experiences like that in Brazil, and I'd like to hear from you. It may look a little bit radical, but anyway, the problems we face now, environmental issues, violence, drugs, mental health, really need something like health in all policies from the governmental point of view. I'd like to hear you in these two issues. Thank you very much again. It was a pleasure.
And I hope you understood Dr. Moda through his heavy Brazilian accent, but it was actually a Harvard accent that he has his M.P.H. from Harvard, and Dr. Coe also is Harvard trained, so they have this thing going on, Harvard thing going on. Our last guest, Dr. Sarmila Mazumdar, is here from New Delhi. She's the Deputy Director of the Center for Health Research and Development, and focuses on community-based trials to improve the public health. There's a lot of experience in working with the community, and I look forward to getting to know you better and one day visiting you in your country. So,
thank you, sir, for the very enriching, informative, and interesting presentation. Very rightly said, we are many countries and one planet, unity and diversity. I will raise certain issues from the perspective of developing countries, particularly India. As you have rightly said, that there have been improvement in many spheres, but there are several challenges which we still face in India. One of the major challenges is achieving the MDGs just 2 years down the line. Problems can be many. There may be inadequate human resource, poor infrastructure, management incompetence, or lack of healthcare financing. Additionally, reconciling the rapid urban growth with the goal to develop or create healthy cities is posing a major challenge. And local communities still have not been able to establish the integrated primary health care Although comprehensive primary health care was advocated in the Alma Ata conference, the agenda soon shifted to selective primary health care. And the emphasis on the vertical diseases, for vertical control programs for diseases, has almost crippled the already weak primary healthcare structure. So that is another major problem. And we are undergoing an epidemiological transition with dual burden of diseases, infectious as well as non-communicable diseases. Another big question is whether the aid that is given to developing countries, is it being optimally utilized? Because developing countries often face the challenge of investing in technological development or other competing priorities and investment in capacity development, which is a major problem. Because critical health workforce shortages exist in almost 57 countries worldwide. So access, as we all know, access to minimum health is the basic right of each human being. We need global cooperation to generate knowledge and solutions through research. Research that is collaborative and interdisciplinary, that provides high-quality learning and cross-cultural understanding. Innovations on how to design and deliver healthcare is a requirement of today, especially in India. It would very much be appreciated if collaborative research between India and US institutions and researchers is promoted and tailored to the public health needs of a country, which are implementation research in the areas of known proven technologies which are not being implemented. There are several commodities, the UN commodities, which are still underutilized. We need innovations on how to use them. We need innovations on how best to use ICT to reach to people who are living in remote, hard-to-reach areas. Collaboration in developing technologies is very much desirable. We need to develop technology which is more relevant, affordable, and of course keeping the end users in mind. Capacity building, collaboration in that sphere is very much required by our country, and we would be really grateful if we can get US collaboration in this front, because we all know human resource is critical. And in India, enough opportunities are not generated for training in research. There are NGOs which provide assistance, but mostly to program delivery and not to research. So that would be a very important sphere where we would like collaboration. So thank you, sir.
So I can promise you the comments from our reactor panel were not prearranged. They're spontaneous, but they complement each other beautifully. And Howard, I'd like you to return up here if you will. And I heard comments around commercialization, comments about translation, and comments about collaboration. And perhaps you can address those as you'd like.
In how much time?
3 minutes.
3 minutes. Okay. Well,
And then we'll open up for discussion.
great. Well, what a fascinating conversation this is. I think the overall message I want to convey to all of you, particularly the young students here, is that if you want a fascinating career, do public health, stay in public health, and keep your perspective as broad as possible. This is an area that's getting more interdisciplinary by the minute, and even those of us who have been this for a long time are forced to learn new things every day, bring in new non-traditional partners who have special skills and disciplinary expertise that we might not have. So here I am, a physician. I'm learning about economics, I'm learning about business, I'm learning about return on investment. I'm certainly learning about policy and politics, I'll tell you that. Looking about how the legal system works, and then all of it is how you best interact with all these groups and stakeholders in order to drive a common mission. So for my colleague from India, you mentioned repeatedly the capacity building theme, and these tough goals that we're trying to reach have no magic solutions. You have to get involved and scope out the landscape and see who your allies and partners can be, and you need tremendous will and also, if I can say, political and interpersonal skill. And that's where we need to go. The capacity building issues are global, because we can set out these goals and targets but unless we have communities working together in partnership, we're not going to get there. That's why I've gravitated through my whole career to people who work well with other people, who can build partnerships and collaborations and make things happen when others might not. Now, with respect to health and all policies that Dr. Moto was talking about, that's the social determinants at work again. One example that we have right now in the U.S. is the National Prevention Strategy that involves not just the Department of Health and Human Services, but all 17 federal agencies. We're working with housing and urban development on smoke-free public housing, for example. We're working on transportation to make sure that environmental impact statements are made before new interventions are rolled out. We're working with the Department of Education on physical activity in schools. So that broad interdisciplinary collaboration, again, is a huge theme. And we're trying to bring health into all discussions. That's what the social determinants approach is all about. And then my colleague from China mentioned the commercialization and globalization themes. We are in an environment like, let's say, for example, the trade issues around tobacco are ones that are garnering a lot of attention right now. And that's a very intense conversation that's not just a health conversation, but a business and trade conversation as well. So in short, if you want to stay engaged, relevant, active, you have to keep stretching yourself to keep learning about these new areas. No one person is an expert, and the more you can push yourself to learn, but also engage other non-traditional partners, I think you're going to be a good public health leader for the future. That's really what it's all about.
In keeping with Dr. Coe's remarks, let me acknowledge we have at least two deans here from other colleges at the university. We have the dean of the Andrew Young School of Policy Studies,
Wonderful.
Mary Beth Walker, and then we have the dean of the School of Nursing and Health Professions, Peggy Bowman in the back.
Wonderful.
So we get it, and we're trying to make it happen. And we see the interconnectivity between clinical and policy. And,
Great.
That's the beginning of a health and wealth perspective.
Great.
We're just going to open this up for a few minutes for questions. We have a microphone. We see some hands. I'll let you, and try, as you all know, who go to meetings, try not to make a speech, but to ask a question.
My name is Alexandridis, and I'm a professor emeritus in international business at Georgia State. I wanted to thank you very much for coming, because in your honor, my wife, after many years, has quit smoking.
Oh, congratulations. That's great. That's great.
And I wanted to ask you, I started my career at the UN, and at that time, WHO was a very active organization. Obviously, there were not others to help out as much as they can now. The US has such a great lead. I mean, I had a 6 bypass operation, and even my surgeon said, you've got 10 good years, and I'm already 18 into this and going strong. But this blessed country is health-wise so much ahead of so many others. What it is that we're doing to help other countries come a little bit higher in their medical and health, services?
Okay. Well, I am so glad that my colleague from Brazil mentioned that when you have common goals, it really mobilizes people and drives action. So again, I'm just thrilled that the UN put out health, and in particular non-communicable disease, as a theme in 2011. For only the second time ever, they talked about health as a UN General Assembly topic. I've also just, by the way, had the honor of being at a panel with Secretary General Ban Ki-moon from the UN, where we had a similar discussion like this about global health and US health. So we're in a time where we look around the world and see many colleagues doing some extraordinary pioneering work in one area or another. And if we can just teach each other what best practices might be, and then put those common global goals in front of us, once the MDGs end, we're looking forward to establishing the next set of goals. I think that's one way where we recognize leadership around the world and then learn from our global partners and say, gee, they tried this in this country, can we try it in ours? That's sort of that sort of thing. And I think you heard that theme coming up from my colleagues just now.
And Dr. Koh mentioned earlier that that meeting in New York was the beginning of the Korean movement, with two Koreans on the panel together, the Secretary General of the UN and Dr. Koh. I know the microphone's out there somewhere. Oh, please, Arpan, please.
Arpana Verma, University of Manchester in England. Thank you very much from our side as well for both yourself and the panellists. I think you'd agree that many of the comments that the panellists made, we are seeing in our own countries and within our cities where we have differences in health outcomes that are comparable to the differences that we see between countries in both the low and high income for life expectancy. And I just wondered really about the fact that our neighbourhoods are seeing the children having a lower life expectancy than their parents, and the impact of that for economic growth and the commercialisation that's already been brought up, and what the leadership, health advocacy and literacy for the US, because you can't untangle public health from global health. And we've looked to you really with your groundbreaking work for several years now, with envy, and we'd be interested to know about your thoughts for that work in our cities.
Well, thank you very much. We could answer that in so many ways. I mean, the bottom line, to answer your question, is that place matters. Place matters, and that health is not just an individual issue, but a community issue. There's a wonderful line from Healthy People that the health of the individual is almost inseparable from the health of the greater community. That's why in public health in this administration, we're talking much more about community-based approaches. It's fine to educate individuals, critically important, but at the same time, we also have to address entire communities. And we also know from what you just commented that there are disparities by community or by state or by country, by economic background, from high versus low and middle income countries. So place matters, and when you want a public health approach that's going to work, it's got to take that broad perspective and tackle the community as well as individual issues at the same time. So that's what we're trying to do. None of this is easy. None of this is easy. And that's why prevention needs colleagues like you to keep at it and make it a lifetime commitment, literally, because this is always unfinished business.
Hi, thank you for the great speech. I was intrigued by your comment on how the place where people pray actually makes a great difference in health. So I would love to hear your thoughts about how do we involve religious institutions in terms of promoting health and delivering these interventions that perhaps can be more effective through these places.
What a wonderful question. So we have actually, under this administration, a faith-based and partnership office in each agency throughout federal government. And the explicit charge is to work with religious and faith leaders, agency by agency, and in our case, of course, working on health issues. A great place to talk about prevention and public health is in a faith setting. And if you do believe in the concept of spiritual health, they all merge together. We have also found that in many communities, it's the faith leaders that are often consulted first about devastating health issues. It's often faith leaders who are consulted first about devastating mental health issues, for example, where when patients have nowhere else to go, they go to their place of worship. So I've had the privilege of meeting some incredible faith-based leaders who have said part of my mission in being a good faith leader is being a good public health leader. One of them told me that's what the Ministry of Public Health is all about, which I'm pleased to repeat to you. I think that's an incredibly rich potential area for further collaboration. Again, now as an Asian American in Korea, the church is a huge factor in the social life of Koreans and Korean Americans. And that can be a place where we can do more outreach and more education and talking about prevention. And another place where we can just express gratitude for the gift of health that we have, which is so fragile. So thank you. I love questions like that, as you can see.
Hello. I am from Mongolia. I'm a Fulbright student. I just finished my M.P.H degree here. Thank you.
Yeah, we met, and I'm going to your inauguration as health minister in the next 5 years, right? Maybe 10 years.
Personally, I did some great changes. I quit smoking, and
Great.
Thank you. And I realized that in my country there are, as you know, in developing countries, governments are such an important, power that can literally control the way how the country works. And I realized my country, there is no chronic disease management program. They want to fight chronic disease without the management plan. They want to fight smoking, but without the quit line, without providing support that people can quit. And I realized the government is not doing their job. Maybe they don't know. Maybe they are not updated, but I am. But I'm so little. They don't hear me. But they can hear you, and also they can hear the other institution.
All the way from Mongolia, they can hear me?
So I was just wondering, how do you see, maybe the global health needs a little bit different approach through governments, because people like me are just, I'm trying to develop a quit line and hopefully a chronic disease management plan in Mongolia, but I'm not sure if I can accomplish.
Good.
So
Well,
I would like to hear you.
first of all, you have the commitment and the mission in your life, obviously. Otherwise, you wouldn't be here. So thank you for doing that. And country by country, it differs on the role of government in promoting healthcare and public health. So that's a fascinating conversation that's part of the global health conversation. In so many areas in healthcare and public health, one person standing up can start something very valuable. So that could be your role. So that's great. Having said that, it's very rare that one person can do the job completely by himself or herself. You almost always need a coalition or a partnership of some kind. So you might be the person who starts the change movement, but then you need to be a great leader in bringing in others who have skills that you don't have to complement approaches. So like in tobacco, you need a quit line, you'll need outreach, you'll need research. And you just have to start with where you are, be strategic about it, hopefully bring some attention by standing for something. A wonderful colleague of mine said, if you don't stand for something, you'll fall for anything. And I love that quote. But if you just get up and stand for something, you can start it, and hopefully you can bring other partners by your side. So thank you for your commitment, and I'm looking forward to going to your inauguration ceremony in 10 years.
Good afternoon. My name is Nila Ellison. I'm from Indonesia. I'm also a USAID scholar, and I'm M.P.H student here. I was selected by USAID in Indonesia to strengthen health system, especially health workforce in Indonesia. And I do believe that everyone here in this room agrees that health human resource is the soul, the heart, and the backbone of the health system. And they are playing an important role not only in the universal health coverage, but also in the global health in the 21st century. My question is that what is the strategy that U.S. has to strengthen and to improve the capacity and capability of the human health workforce, especially for the global health in the 21st century? Thank you.
Thank you. So workforce issues come up all the time. Workforce issues are a big part of our health reform efforts. We need a paradigm shift in workforce investments because we're moving more toward a team-based approach to care in this country. We're trying to promote more primary care clinicians who can be leaders of a team that can put the patient at the center of a so-called patient-centered medical home, for example. We are interested in helping other types of providers in health, not just physicians and nurses, but also physician assistants. Pharmacists are now playing a huge role in immunization and in education about chronic disease self-management, for example. We have a special commitment to workforce issues for underserved in our community health centers around the country. So these are all our investments here in this country about workforce development. Again, and oh, by the way, we also have increasing commitments to community health workers and promotores, now that I know how to pronounce that. So this differs country by country. The workforce and capacity issues are absolutely critical because, again, you need a team-based approach, not only for public health, but increasingly for care. So I'm not an expert in Indonesia, but I'll be fascinated to see how what I said about the U.S. compares to your workforce commitments and progress in Indonesia.
We have gotten the word Dr. Ko and his group are going to have to depart for the airport. They have a Hartsfield flight, and if you know Hartsfield, you need to get down there on time. So we'll have to cut questions now, but I think you know that Dr. Ko is caring and approachable and has an infrastructure. We have a regional health administrator here in Atlanta. We have CDC, and your ideas and questions and involvement are not only welcome but expected. So please join me in thanking you.
Thank you very much. Thank you very much. Thanks to you scholars here. Thank you very much. Thank you. Thank you very much. Thank you.